most of these analyzers now have something called as the switching algorithm, where the analyzer decides based on certain parameters whether an impedance is more suited in this condition or an optical platelet is more suited. And then we have something called as platelet HFC ratio, which is similar to PLR, but also these markers have additional prognostic significance in dengue, as we'll discuss later. We have something called as the high fluorescence IPF. So within the IPF now we have a high fluorescence region which is called high fluorescence IPF. This is the last cell line, the platelet cell line, after the wonderful presentation by ma'am on the WBC cell line. And this has somehow gained more traction in northern India, primarily because of the dengue endemic that is very prevalent in this belt. And a lot of platelet parameters in the last 4 or 5 years have gained more traction. And again, thanks to ma'am, because the original paper came from Hinduja Hospital itself on peak IPF, which set the ball rolling for the last 5-7 years. And I don't know, maybe we have discussed this over 20 presentations or more together. So I've labeled my talk platelet 360 degrees, as I want to cover the platelet parameters from all corners. So that's why I named it 360 degrees. So we all know that platelets are small round cells that are vital for normal blood clotting, and the normal range in an adult patient is 1.5 to 4.5 lakhs per microliter. And they help in stop bleeding using 3 mechanisms: adhesion, clumping and aggregation. So platelet counts can be increased in myeloproliferative disorders, acute and chronic inflammatory conditions, even iron deficiency anemia. They can be decreased in long-term bleeding disorders, thrombocytopenic disorders and even megaloblastic anemia. So before dwelling any further, let us look at this histogram. This is called the platelet histogram. This is a very important cog in the wheel. So we have here 2 flexible discriminator, the lower discriminator at 2 to 6 femtoliters and the upper discriminator at 12 to 30 femtoliters. And we have one fixed discriminator in the middle called at 12 femtoliters. So if the histogram starts from the baseline at the lower discriminator and ends just before the baseline at the upper discriminator, this is called a normal platelet histogram. And all the cell population to the right of the 12 femtoliter constitutes the platelet large cell ratio along with MPV. Both of these are indices. So along with this MPV, this is an index of giant platelets. This broad base at the bottom constitutes the platelet distribution width. So this is how a normal histogram would look in most CBC analyzers. So if you see this kind of an histogram, I would be okay to even report a platelet count of 20 to 30,000 without even a review. But if my histograms look something like to my left or to my right, then I would be very wary to even report a platelet count of 1 lakh. This could be topsy-turvy. So broadly we can have 2 kinds of abnormal histogram. One at the lower end where the lower discriminator exceeds the preset height by 10% or more. Now this is usually seen because of high blank values, cell fragments, bacterial contamination and platelet aggregates. The most common among these is contamination of your reagent. So if you see this kind of a platelet flag, go check your reagents, more likely the diluent, where there will be some amount of bacterial contamination in your reagent. On the contrary, this is the more common platelet flag that we see, where the baseline doesn't touch the upper discriminator and exceeds the height by about 33%. In these kind of scenarios, it is difficult to differentiate giant platelets or platelet aggregates from microcytic RBCs or fragmented RBCs. So hence came the use of the optical platelet, where you could differentiate giant platelets and platelet clumps or RBC fragment or microcytic RBCs better from each other. So the common flags for platelets are platelet abnormal histogram, thrombocytopenia flag, thrombocytosis flag or platelet clump flag. So broadly, if you see any platelet flag, the ISLH criteria says that you must do a smear review. So coming to methods of platelet impedance estimation, the most common, the most widely used and the most accurate method still today is the impedance-based method, which we are using. So we did a study in Delhi NCR. 98% of all Delhi's labs were using only impedance-based method to do their platelet estimation. So, but as I said, that in conditions where you are seeing a lot of peripheral platelet destruction like dengue, ITP, or microcytic hypochromic cells, or where there are fragmented RBCs, this may not be the most desirable method because of the difficulty in differentiating giant platelets from microcytic RBCs. So hence comes the optical, or some people like to call it the fluorescent platelets, where you are using a dye to stain the fluorescence. So these are better methodologies in cases of peripheral platelet destruction, especially dengue. So optical platelet came into vogue because of that. And then most of these analyzers now have something called as the switching algorithm, where the analyzer decides based on certain parameters whether an impedance is more suited in this condition or an optical platelet is more suited. Then we have something called as the immunoplatelets, where CD61 FITC tagged antibodies are used in certain analyzers to measure platelet count. Actually, this is the closest to the international reference method of flow cytometry, but the problem here is the cost. So it would cost something like a bomb 2.5 thousand odd INR equivalent to do a platelet with this method. And with all governments gunning for 50 rupees capping, I don't think this is plausible in the Indian scenario. So last but not the least, we have the manual platelet estimation using chamber or smear validation. And this has helped us in good stead for all these years where we were purely relying on the impedance based technology. So a lot of us used to do our smear reviews to estimate all those giant platelets and stitch up the manual correct platelet count, and it still holds good because vast majority of India is still on impedance based methodology. So coming to the platelet parameters, of course we have the platelet count, then we have mean platelet volume and platelet large cell ratio, both of them are indicative of giant cell platelets. We have platelet distribution width akin to RDW, which is indicator of platelet anisocytosis. Then we have this giant slayer called immature platelet fraction, which has gained a lot of traction, especially due to dengue, and it has got a good prognostic significance in looking at recovery of dengue patients from thrombocytopenia. Then we have some interesting markers, some of them ma'am has already covered in her presentation, like PLR and its utility. And then we have something called as platelet HFC ratio, which is similar to PLR, but also these markers have additional prognostic significance in dengue, as we'll discuss later. And last but not the least, we have something called as the high fluorescence IPF. So within the IPF now we have a high fluorescence region which is called high fluorescence IPF, and this I will discuss in a little later because there is related stuff that I need to talk. So this is how the platelet histogram and scatter plot looks like. This blue area here is the area of the optical platelet, and to the right and slightly tilted is the area of the immature platelet fraction. So if you look carefully, immature platelet fraction is not only having higher fluorescence but is also having higher size. So actually immature platelet fraction is not only measuring reticulated platelets but is also measuring giant platelets. So it's actually a combination of both giant platelets and reticulated platelets. So may not always be a direct instrumentation to measure only reticulated platelets. So this is the area of the optical platelet. So this is the workflow of the platelet as we do in our laboratory. So first of all, we look at the platelet histogram. If the histogram is not okay, we run every sample on the reticulocyte mode to do the optical or the fluorescent platelet. However, if the platelet histogram is normal, then we look at the count. If the count is more than 100, the histogram is normal, we report the platelet as it is without doing any smear review. If the platelet count is less than 1 lakh, we again run the ret mode and do both impedance and optical platelet. Just a word of caution, in extremely low platelet count, say less than 50,000, I would still recommend you to do a smear evaluation even if you have facility to do optical platelets, because optical platelet is not the panacea to all your problems. There are conditions where optical platelets could also go wrong, especially with cancer chemotherapy patients and with patients of severe hemolysis with a lot of nucleated RBCs, as the case that I showed in my RBC presentation. So IPF is basically useful in conditions where there is peripheral platelet destruction like ITP, like dengue, like TTP. Also, it is a very useful for recovery of bone marrow post-transplant. It is the first indicator of bone marrow regeneration. So IPF can differentiate aplastic hypoplastic anemia from ITP and is also a prognostic marker of platelet recovery in dengue, in ITP as well as in bone marrow regeneration. So this is the scatter plot that I just showed you. So what are the ISLH criteria for platelet review. If the platelet count is less than 1 lakh, if it is more than 10 lakhs, or if you see any of the platelet flags or platelet clumping flags, you must do a smear review. I just wanted to show a case to differentiate where optical platelet is better than an impedance one. This was a Bengali patient, 32-year-old male. He had an history of fever for 6 days and his dengue NS1 antigen was positive from our lab. So if you look at the indices, the platelet count was 1,26,000. It had done by both impedance and optical. The IPF was pretty high, 61.7%. And even if you look at the MPV, that was high, platelet large cell ratio was also 61.9%. So there was a lot of giant platelets also in this case. So if you look at this research parameter mode, the impedance was 41,000 and the optical platelet was 1,26,000. So if I would have only relied on impedance count, this patient would have been admitted into some hospital and would have been probably undergoing some IV solutions, where he could have been very well managed from home. So that is what optical platelet brings in a dengue patient. This patient, in addition to having dengue, had another problem. This was a patient of Harris platelet syndrome, which is very prevalent in eastern parts of India. That is why it had macrothrombocytosis. And that is where the question that you asked me about IPF, the ballpark figures are often misleading. The ethnicity is tricky, and apart from Harris platelet syndrome, we also have Mediterranean platelet syndrome, especially of people coming from erstwhile Pakistan, the more northwestern frontier province like Peshawar or Multan. Those are the people also have these hereditary macrothrombocytes, and they could also have high IPF like in the Harris platelet syndrome. So if you look at the platelet histogram, it is all over the place. It is telling you a story that smear review must be done. And if you look at the red scatter plot here, if you look at this green area out here, this is the area of the IPF. And you can see that virtually 2/3 of the optical platelet area has been covered by the IPF zone itself. So this is the same platelet scattergram that I am showing in a little more detail. You can see that the green area of the IPF is highly augmented in this case. So this is the second case. This was a 6-year-old female who had come to us with history of viral fever for 2 weeks. And if you look at the indices, the platelet count was 9,000. The IPF was 34.3. The machine could not compute the MPV. And if you look at the platelet histogram, this is showing thrombopenia. And if you look at the scatter plot, the IPF is again significantly increased. Dengue NS1 antigen antibodies were both negative, and the patient was presumptively diagnosed to be acute ITP and was followed up after corticosteroid therapy to us. The platelet count increased to 97,000, and look at the IPF, it has become normal, 4.8%. Our IPF normal range is up to 7%, but again a caveat, every lab must compute their own IPF because different manufacturers, different reagents, it's a calculated parameter, different algorithm also. Even within the same manufacturer, if you are using 2 different instrumentation, it could have slightly different biological reference. And the same platelet histogram has become normal. And if you look at the red scatter plot, the green area of the IPF is highly diminished compared to the earlier scatter plot. So this is response to therapy in an acute ITP. So the diagnosis was acute ITP simple. This is the third case. This is a known case of chronic ITP in remission. I am just showing you to show what IPF can be in chronic ITPs. Unlike acute ITPs, even with normal or slightly low normal platelet counts, patients of chronic ITP can continue to have high IPF values. So the platelet count here was not too low, it was 1,18,000. But look at the IPF, it is 53.2%. So we reported IPF as high as 70-80% in chronic ITP patients. So if you look at the optical, it is 118, impedance is 97. That's not too much of a difference. And even the high fluorescence IPF is pretty high, 32.7%. High fluorescence IPF in our setting was, our normal range was up to about 3%. So this is the scatter plot. You can see that the platelet histogram is all over the place. And the ITP again constitutes nearly 70-75% of the whole area. There is a strong green scatter plot out there in the red scatter plot. So chronic ITP can continue to have high IPF values irrespective of the platelet counts. So this is an important parameter, high fluorescence IPF. It came with a lot of fanfare. So the logic was that probably this zone will be able to differentiate giant platelets from reticulated platelets and will take care of some of the ethnic variations that we are encountering in IPF. So we decided to do some internal study in our own lab. So we first, before anything else, you have to establish biological reference interval, what is normal high fluorescence IPF. So our normal range had a mean of this is IPF. Our normal range for IPF was up to 6%, and for high fluorescence IPF it was up to 2.1%. So because it is a sub fraction of the total IPF, then obviously the high IPF range would be significantly lower than the total IPF range. So with this is a prototype case study, but we did about 30-40 cases of purely ethnic cases coming from Harris platelet syndrome. So this was again a Bengali patient. The optical platelet was 142, impedance was 118, the MPV was 17 femtoliter, platelet large cell ratio was 74.4%, the IPF was 22%. There was not much thrombocytopenic challenge, but the IPF was again higher because of the Harris platelet syndrome. So the same biological reference interval in a North Indian population, which is 5 to 7%, becomes about 15 to 20% when you move to Calcutta site. And the high fluorescence IPF was also high, 8.7%. So this is that prototype case. You can again see that the typical platelet histogram is that of giant platelets, and the red scatter plot is again showing pretty high IPF. And that area to my right, which I am unfortunately not able to show, that is the zone of the high fluorescence IPF. So I will now show 3 of our studies that we had conducted over the last 4-5 years to establish the role of IPF and certain other markers as a prognostic marker in dengue patients. So this is the predictive markers in dengue, the journey so far. So we began our first study in 2015, which was titled Peak Immature Platelet Fraction as a predictive marker of platelet recovery in dengue patients. We presented it in the research paper competition at AIIMS in 15. So the objective was that we wanted to establish peak IPF values in thrombocytopenic dengue patients. We then wanted to establish time to platelet recovery from these peak values for each one of these patients. And if majority patients showed platelet recovery within defined period, we could use that as a predictive marker. So we used dengue IgM and NS1 kits from PanBio and Bio-Rad, which were both US FDA approved kits. And optical platelets and IPF we computed on the Mindre BC6800 hematology analyzer. So we used a simple 4-step methodology. We first selected patients with clinical symptoms of dengue which were confirmed either using dengue NS1 ELISA or dengue IgM capture ELISA in the initial scope of study. Then patients who did not have thrombocytopenia were excluded from the group because they did not pose a challenge for IPF to get elevated. Then we further filtered these patients to show patients which had both rising as well as falling trend. So if we had 3 or 4 values which were just falling or just rising trends, we again excluded those patients from our study because we wanted to establish a peak IPF value for each one of our patients. So at this stage we had about 50 patients left. Then we monitored optical platelets for these patients daily till significant rise. And time to recovery from the peak IPF values were calculated for each one of these patients. So again we first established biological reference interval for IPF which was up to 6.6% using 992 patients. And all the patients were smear validated to look for platelet aggregates or giant platelets. And we did a precision study also to look at the CV percentage. So at very low normals the CV was 6.2% for optical platelets, and for IPF it was 6.4%, which was pretty robust. So this is our results. As you can see that our peak IPF frequency distribution was all over the place. So one thing was very clear, we could not set ballpark figures on peak IPF values. I could not do a single IPF and say that okay, your patient is going to recover in 42 hours. That would be a dangerous statement to make. So my peak IPF values range from 5.5 to 38.7%. with a mean of 13.5 and a standard deviation of 6.4. 86% of the patients whose peak IPF values were above 20% were ethnically from West Bengal, Bihar and UP, Eastern UP, typically the Harris platelet syndrome belt. 100% patients showed platelet recovery and 86% of them within 72 hours. And peak IPF values showed a strong correlation with time to recovery of platelet counts. So if you see this graph at the bottom, this green is showing IPF. At day 3 or day 4 it is reaching its peak position and then beginning to dip again. Similarly on day 5 the platelet count begins to rise. So roughly the gap between peak IPF and the rise of platelet count is 48 hours. So this can be very helpful in A, making transfusion decisions for patients, B, in a crunch situation, it can even be useful to manage who should be hospitalized and who should not. So sometimes what happens, some VIPs are occupying beds which they don't need to occupy because of the panic, because your platelet is falling from 4 lakh to 40,000 and everybody wants a hospital bed in Delhi. There aren't enough beds in a dengue epidemic. So the conclusion were that peak IPF is a promising predictor of recovery of platelet count in dengue patients. A single IPF value more than 10% is not a reliable marker of platelet recovery within 24 to 48 hours. And peak IPF value in dengue patients of different ethnic groups can be a subject for further study, which it was. So subsequently, there were some good papers from Calcutta which showed us that there were different biological reference interval from the eastern population. So as they say, you are first time lucky. We got the first prize for this paper in 2015 in AIMS. So encouraged, we then tried to do another study in 2016 in this same state in Rajasthan. We did a paper, research paper in RNT Udaipur. There was an RP competition. And we did a comparative study on IPF on Mindre BC 6800 with Sysmex X10000, which were the two most common analyzers which were doing IPF at that time. So we wanted to see whether IPF values from both the analyzers were showing some correlation or were they totally discoherent with each other. So we tried to evaluate the IPF parameters of these two analyzers. So again, we used IPF on Mindre BC 6800 and X10000 and smear review we did on Zeiss microscopy. So this had to be a multicentric study because we don't have the Sysmex analyzer in our lab. So we did this study in collaboration with Medanta Hospital and another lab situated in Chittaranjan Park in Delhi. For those of you who know Chittaranjan Park in Delhi, this is like mini Calcutta within Delhi. It is basically full of Bengali patients. So I wanted those typical Harris platelet syndrome mix into my study. So we analyzed both optical and IPF on both the analyzers and we segregated the groups into two equal halves. IPF less than 6% and IPF more than 6% because around 6 to 7% was our cutoff. So we wanted to do a Deming regression. In an ideal Deming regression, you need 50% normal and 50% abnormal patients. And all selected samples were analyzed on X10000 within a time interval of 6 to 8 hours because as you know, IPF has got sample integrity issues also. And smear validation was performed to eliminate cases of both WBC and RBC fragments. So you can see that the R values for IPF were pretty robust. All were in excess of 0.9. Although the R value for IPF less than 6 was significantly better, 0.972 compared to 0.901 for IPF more than 6, but that is expected because IPF more than 6 would be more thrombocytopenic patients. So the CV percentage would be definitely higher in more thrombocytopenic patients. This is the Deming regression graphs for the same. They are all showing good correlation. So the conclusion was that the regression analysis between IPF of both analyzers showed good correlation, and although they are not exactly apple to apple comparison, but can be used to look at trend analysis from one analyzer to the other. So we got a third prize for this paper in Udaipur. And this is the paper we presented this year in Vancouver at ISLH, where we did a clinical evaluation of various predictive markers of platelet recovery in dengue patients. So now IPF is not the only surrogate marker for platelet recovery. We are now looking at a plethora of markers, including high fluorescence cells, just as ma'am told. Basically, high fluorescence cells are nothing but your TERK or your Downey cells or reactive lymphocyte, whatever you want, virocyte, whatever you want to call them. Now we put a numerical number to it and the machine computes it. There is a biological reference interval. Most places the normal range is between 0.4 to 0.6% based on what the analyzer is. So a rise in high fluorescence cells is also used as a surrogate marker to look at platelet recovery in dengue patients. Along with it, we are using some other markers like PLR, PHR, and look which is a better marker among all these competing markers. So the objective was to evaluate different parameters and their trends to predict platelet recovery within a defined period. So what we did was we first took dengue positive patients confirmed using NS1 or dengue IgM ELISA with platelet count less than 1 lakh. Patients were further filtered to include only those exhibiting both rising and falling trends of platelet and predictive markers of the study. So we wanted either to establish the peak values or the nadir points for each one of these parameters. And the criteria for significant platelet recovery was an increase in platelet count by 10,000 or 10%, whichever is lower over the preceding value. And we classified these markers into peaks, troughs, and also into jumps and falls. So for certain markers like high fluorescence cells, the recovery was actually coinciding with platelet recovery. So it was not giving us a good enough window to make a predictive marker. So what we tried to do was to borrow from one of the innovative studies done by Dr. Dadu from BLK, where she said that, look at HFC jump instead of the HFC rise itself. So if the HFC jumps 3 to 4 times from day to day, that point you should consider as your base point. So I'll show later. So these were all the parameters that we evaluated: mean platelet volume, IPF, high fluorescence IPF, high fluorescence cells, neutrophil lymphocyte ratio, PLR, and platelet HFC ratio. So the first 3 parameters were showing a peak value just like IPF. In HFC, along with the peak, we also measured the HFC jump. So that jump was classified as 3 to 4 time rise from day to day. So that was considered at the base point. And for neutrophil lymphocyte ratio, platelet lymphocyte ratio, and platelet HFC ratio, along with the trough or the nadir points, we also were evaluating falls. So that fall was classified as more than 50% fall intraday. So this looks like a busy chart. So the parameters that were okay within 24 hours, like HFC, which was 52%, or PHR, which was 46%, or MP, which was 59%, were actually not good markers. So the parameters which were evaluating later, which had a delta value between 96 hours and 24 hours, was actually which gave us significant window for us to make it a predictive marker. So we looked at the delta value, which is giving us the best delta value. So as you can see here, that the PHR fall amongst all these parameters is giving us the best delta value of 71%. And similarly, if you look at conventional parameters, the HFC was giving you the best delta value of 46%, closely followed by IPF, which was 45%. So just to make things simpler, this was within 24 hours. So the parameters which were giving within 24 hours were not actually providing enough window for predicting platelet recovery, were rather coinciding with platelet recovery. So NLR and MPV and PLR were actually were not very good, same PHR, they were not very good markers. That is why we tried to look at their trough and fall. So this is the delta value 96 hours minus 24 hours. So the best predictive marker amongst all these markers were the platelet HFC ratio, which was actually scientifically also correct, because as dengue progresses, the platelet count begins to fall and the HFC begins to increase. Typically the HFC begins to increase from day 4 of fever and continues to increase till platelet recovery. So when you take a falling parameter in the numerator and a rising parameter in the denominator, your decreasing effect gets exponentially augmented statistically. So this is, again, I am only looking at the fall and jump parameters. I put all the conventional parameters all. So amongst these 4 parameters, the PHR fall brought maximum sensitivity to the table. It helped 71% of the patients. So in conclusion, we could establish clinical utility of all the above markers for platelet recovery, and PHR fall was the most efficacious marker amongst all these parameters evaluated. PHR trough and PHR fall were the best predictors of platelet recovery amongst the peak, trough, and rise fall parameters respectively. And PHR trough had a delta value of 52% and PHR fall had a delta value of 71%. So even if you look at not jumps and falls, if you just look at peaks and troughs also, then also PHR is the best predictive marker of platelet recovery amongst all the plethora of markers available. So we presented this paper at ISLH Vancouver on May 10th this year, and with these words I'd like to thank you all.